Actually, looks like a couple dozen. Okay.
I heard that. Good morning, everyone. People on the phone, can you hear me okay?
Yes,
Yes, Lorraine?
Okay.
Yep.
Excellent, thank you. We are going to get started in about a minute, but I did want to, this is Lorraine Dew, speaking from CMS, and I did want to get some administrivia taken care of quickly before we launch into our session this morning from the Multimedia Center. First of all, there is a sign-in sheet with chocolate. Apologies to those of you who are not with us in the room, but we always have to have chocolate, even though there's no eating in this room. But I do owe it to the wonderful people from the Media Center who have managed my stress level, but you can also have some here. So the sign-in sheet, the purpose of that one is so we can track the number of people that are here. If you are not in the room with us, if you would just send me an email to let me know that you're on the line. I have created a Survey Monkey for afterwards, which I'll be sending out to everyone so we can gauge how you thought about the session and what we can do in the future related to fire. So for everyone who's on the list already, that will be coming out to you tomorrow. It'll be really helpful if you do respond to it, but that's partly what the sign-in sheet will help us with. Third thing, super important, is our traditional phone etiquette. I don't have a way of controlling the mute button because if I do put it on mute, you won't be able to hear the wonderful presentations today. So I beg of you, take 5 seconds now for those on the phone. Just make sure to mute your own phones once we begin after some initial welcoming comments. And please do not put your phones on hold because we will get your beautiful music. So we would really appreciate that for those on the phone. Anna?
Is this being recorded?
It is being recorded and filmed, yes. So it will be available afterwards for anyone who is not able to attend or who's not going to be able to see the actual demonstration. So that said, those are my just administrivia items. I would like to ask if Mark Rocha was not able to be with us today. He's in Atlanta at a conference. If he could just say hello from afar briefly, and then we'll ask Alex just to say hello as well before we launch into our presentation. Mark, I think you are on the phone.
Yes. Yes. Can you hear me?
Yep.
Hi. My name is Mark Rocha. I'm a physician informaticist and Chief Health Informatics Officer within the Health Informatics Office at the Office of the Administrator. And I would like to thank you for coming to this session today. I would like to thank Lorraine for organizing this fire educational session. I think it's very important, specifically because CMS is already doing several different initiatives that you will hear today about that relate to fire and that are based on fire. And because fire is really important for facilitating exchange of clinical data between providers, patients, and payers, and our ability to transition from fee-for-service to value-based care. So having said that, I would like to introduce my Deputy Chief Health Informatics Officer, Alex Muggy.
Thanks, Mark. Hi to everyone here in the room. I'm Alex Muggy. Work with Mark in the Health Informatics Office. We're a relatively new office. I think we became official only about 5 or 6 months ago. So if you haven't heard of us, that could be why. But we're hoping to use opportunities like this to get to know all of you. And we're very grateful to see such a diverse group of folks coming together to talk about fire today. The administrator has made it very clear in speeches and her outreach to various organizations that CMS is taking an API-first approach to data sharing, and this is something that we're looking at for the data that we share internally as well as with stakeholders. And to that end, as Mark mentioned, we have already initiated many projects to promote the use of APIs, and in particular, fire-based APIs, and so that's why we wanted to have a session like this, and very grateful to Lorraine. Thank you for setting this up. to just start talking about different ways that we can, well, first learn about fire and then figure out how we can use it in our different work and spread throughout CMS. So a couple of things just to note that we've already started is we do have an interoperability and patient access proposed rule that's currently out for comment that impacts our health plans, clinicians, hospitals, just about every entity that we regulate has a little bit of something in that rule. It's currently out for comment, and it does highlight the use of the FHIR-based APIs for much of the business to do with CMS. And at the same time that we put our rule out, ONC also put out a proposed rule highlighting the use of FHIR for EHR vendors. So we are sort of coming at this at all angles, which we feel is critical to get alignment of industry. If everyone's functioning on the same standards and using the same language to communicate, that will help us to ultimately get to better interoperability and data exchange across the healthcare market. So that's why we feel that this is a critically important topic to cover, and we're, again, very grateful that everyone was able to join us today. So,
all right, great. Thanks very much. Again, thanks everybody who's joining both here and on the phone. And now I'd like to introduce our presenters. Kevin Malloy from MedStar and his team are going to join us. I will have them introduce themselves, but I just wanted to say I actually met them, Asymmetric and the MedStar team at Datapalooza when they were doing their demo, and I wanted them to share because it's a great way for non-developers to see what FHIR is able to do from a development perspective. And using FHIR and apps. MedStar has developed, has won innovation awards. They won an award from ONC for what they had done. They got a LEAP grant from ONC, and they also won the Secure FHIR Server Challenge. So they've got some good talent on board, and especially with relation to FHIR and apps. So I just wanted them to join us and show realistically what can be done with FHIR, and I'll let Kevin take it away. And do you want me to run yours, or you're going to actually pick on it? Okay.
So I'm Kevin Malloy. I do emergency medicine at Washington Hospital Center, and I also do some coding stuff. I work at the MedStar Institute for Innovation, which is headed by a guy who actually made his own EHR a while ago. It's actually been sunsetted, and we use Cerner now, a guy, Mark Smith. So he actually taught me how to code some, and I still see patients. So I'm working Saturday, so if you want to get like really drunk in DC and like get violent and have someone to spit at in the ER, you can come see me. I'll be there, I think 11 p.m. to 7 a.m. if you want to stop by.
Hello, everybody. My name is Christine Lakai. I work with Dr. Malloy at the MedStar Institute for Innovation, primarily focusing on informatics.
Hi, everyone. My name is Brian Young, and I'm the Director of Customer Solutions at Asymmetric. Asymmetric is a software development company about 20 minutes south of here, and we work a lot with MedStar. We met Kevin a little while ago, actually at a FHIR class, and pretty soon we saw the way that FHIR might help interoperability and have kind of put our company around some of the promise. So.
And I'm Andrew Marcus, also at Asymmetric, healthcare technologist, and we've been doing with MedStar for a long time. And then also the ONC challenge that she was talking about before.
Yeah. So MedStar won the LEAP grant and still working on it, and Asymmetric won the Secure Server Challenge about a year ago from ONC, setting up the Secure FHIR server, which is actually open source on GitHub, I think.
Yep.
Correct? All right. Great. So we're going to make a FHIR app with you, and with you is in all capitals today, and you'll see why in a second. So Lorraine was mentioning, I've gone to a lot of conferences doing like medical stuff and whatnot, and it seems like they're very formulaic when you go to a conference now, and you're like, you sit down and somebody's lecturing, you got some PowerPoint slides and whatnot. And I swore I'd never do another conference or talk again unless we did something really interesting, right? So Health Datapalooza, which was down in DC just like a month ago, had this wildcard track. And they were like, if you have something weird to do, just put an idea in and we'll consider it and see if we'll have you talk. And we got together and we were like, what could we do that's weird? Like, well, we could make a FHIR app out of people. So we were like, we'll make a FHIR app out of people. Submit it, and the steering committee was like, sure, do it. And we're like, okay, how do you make a fire app out of people? So we've actually come up with a bunch of boards and vests and all this different stuff to illustrate physically how fire apps work. And then we're going to show you how an actual fire app, like a web app, works by opening up Chrome DevTools and looking at one under the hood. Before we start with all that, we thought it would be useful to just kind of level set and do a brief history of fire. So
Yeah, sure. So I'm going to make this incredibly brief. Now, show of hands, how many people here know what fire is? And how many people know from a technical point of view what fire is? Okay, it's pretty good.
Carl Davis raised his hand.
Okay, good. So I'll just talk a little bit about what, FHIR stands for Fast Healthcare Interoperable Resources. And the key part of what I just said is resources. FHIR represents several healthcare concepts: patient, provider, encounter, lab tests, as resources, and exposes them in an API format. And so really the point is to be able to take these concepts and make them interoperable, make it so that both humans and computers can understand the data and exchange it. Next slide. And so you'll see, why FHIR. You'll see that FHIR pretty much mirrors the rise of the internet. And so there were plenty of interchange formats before FHIR. But you'll see that starting with the High-Tech Act and some of the legislation that I'm sure a lot of you were involved with, FHIR was sort of pushed by meaningful use and the idea that the data should be able to be exchanged with no special effort. Next slide. And so really FHIR is being pushed by a technology that is being supported by government and industry, which is really helping drive adoption.
Great. And when we were putting this together, we came to the conclusion that FHIR should not be boring. I make fire apps myself. I actually have a few in production at MedStar. Our fire server at MedStar is actually in production. It's run by Cerner. But we actually make these apps at the Institute for Innovation, and Asymmetric has made a few as well. And we presented at different innovation challenges and whatnot. And when you actually make them, they're actually fascinating to make, and they shouldn't be boring. And some people may think they're boring because if you go to the HL7 website and look at FHIR, you get a very wordy explanation of everything that FHIR is about. And it's really, for somebody who's non-technical, it's really hard to navigate. You'll notice there's a delay on some of these slides. It's because it's actually going from my computer to WebEx to the screen. So if you notice some choppiness, it's like the only way we could pull it off in the room here. And like Brian was talking about, there's adoption in industry. Right now, if you go to open.epic.com, these are all the health systems that have active FHIR servers that are supported by Epic. And suffice to say, if you look at it, scroll down, there are a ton now. When we first started doing this, maybe about 1.5 years ago, there were only a handful. But now there's well over like 300 health systems on Epic that have FHIR servers. These are their public URLs, right? So this is where the actual production FHIR server is standing for Virginia Hospital Center, which is right across the river from DC. Another thing Brian touched on was adoption, and you'll notice if you go to Apple's health medical records app now has a bunch, probably over 250 health systems that let you import data via FHIR onto your iPhone. MedStar Health was part of the first group that allowed patients to do this because we were somewhat early to FHIR. But there are lots and lots of organizations now that you can sign in, get your FHIR data, and get it in Apple Health and encrypt it on your iPhone. And this includes labs, it includes like ICD-9s, 10s, includes a lot of stuff. And just to kind of, as another point with the industry adoption, Cerner, who's MedStar's EHR, they actually host an app gallery where kind of smaller startup type companies and some bigger ones actually have made apps that they sell on their app store. MedStar actually contracts for one of these currently to help with some of the anesthesia workflow. But these are small companies that are making apps that that are living in the EHR that are not the Cerner Corporation, not the Epic Corporation, not Allscripts. So there's actually a lot of different players who are starting to, is somebody's line open?
Yeah. Can folks on the phone just check your line and see if it's open, and if it is, just mute it?
I think that's
Thank
it.
you.
Yeah. So fire shouldn't be boring because it's happening all around us right now, and it's actually very vibrant, and it keeps getting more and more vibrant. All right, so we're going to move on to the hands-on portion of this. What we're going to basically do is go through a patient portal scenario showing a custom API, and we're going to go through the same scenario but with a Fire API, and you'll get a little of that as we go. To show some of the technical stuff, we're going to open Chrome DevTools. I don't know if many of you have played around with Chrome DevTools in the past. Basically, if you use Google Chrome, you can get an inspector to open in any Chrome instance that puts a window here that shows you what's going on under the hood, but you can also see the web page over here. So this is the live web page, and this is what's going on under the hood in terms of network requests and whatnot. If you were curious about, you're like, whoa, those guys were doing that stuff, I could actually go on my computer right now and do that. If you're interested in doing that, you can do the 3 dots up here, more tools, developer tools, and you'll get the same window that pop up. And even if you have Chrome open now, you can try it. It's actually very remarkable that you can look under the hood of any website that's running. All right, so we're going to start with the patient portal scenario. And we have given everyone an envelope when you walked in. This is a vanilla envelope. And inside it, some of them have a golden ticket to fit with our candy metaphor when you came in. So if you have a golden ticket, you're on. Do you have any extra envelopes? I think you only get it. No. So if you have a golden ticket on the back, so the golden ticket looks like this. It says patient network request 1. It's actually 2 network requests. Or patient portal API. We need you to come up because sitting is the new smoking, right? We're going to prove it today.
Or hand it to your neighbor and make them come up.
Or you can hand it to your neighbor.
So
you are network request 1. So let's start with the patient here. Does anyone have the patient?
Patient portal API.
All right.
Okay.
All right. We'll just
you will stand over and
Let me get over.
Okay. So we'll.
Are you the
All right.
patient?
Great.
Hello, Wilma.
Okay. So what's your name, my friend?
Mike.
Mike, how did you end up putting a patient gown on today, Mike?
Car fell on my head. I have a big cranial crack. Need to go to Washington.
Yeah, CPR. That's great. So you are going to be the patient today. We do have a gown for you. It's been slightly used. I'm kidding.
No, I yesterday.
So what we're going to have you do is stand right over there. And network request 1. My friend, what's your name?
Madhu.
Madhu.
Yeah.
How long have you wanted to be a network request?
10 minutes, I guess.
10 minutes? Okay, since we started talking about it. So for the network request, we actually have a hard hat. It is blue because everything made by the patient portal EHR company is going to be coded as blue today. And it is a hard hat because, the web is a very dangerous place. There's all these hackers, there's like all this different type of stuff going on. So you need some protection. So we got the hard hat for you. We'll have to go right over here. And
I'm patient portal.
patient portal, what's your name?
Vicky.
Vicky, so you're going to be the patient portal API. How did you know you're going to be a patient portal today?
No, I have no idea.
No idea? Okay. So we're going to have you put on this vest. So this is the patient portal.
Your gown is fast.
So we work with Metaphor here.
Sorry, I know
It's heavy because medical data is serious and heavy. It's very weighty. You don't want to get out anywhere. So this is a non-standardized API, as is apparent by all the different USB and connectors that come out of it and don't particularly seem to be that easy to use, right?
It's also kind of falling apart.
Some of them are
and,
falling apart. It was glue gun
Not very
together.
stable. Yeah.
So what we're going to have you do is go over for Brian there.
Oh, okay. He's our database.
Right. Brian is our database.
So Brian is our database, and you'll notice that Brian has a box full of different plushy toys, which are representing maybe ICD-9, 10 codes, maybe lab tests like hematocrit. I think there's some gonorrhea in there. Diarrhea to CMS. So you're asked here. All right. So our patient. So instead of getting hit in the head, I know you were about that. Our scenario today is that you unfortunately have been feeling weak, and you're a good patient. So what do? What do all good patients do nowadays?
I'm a doctor.
Oh yes, and some of them do Dr. Google. They could call your doctor. So while you're on hold with your doctor, you're like, oh, I wonder if I can use Google, and you ask Dr. Google, hey, what causes anemia? And maybe does anemia cause weakness? Because a lot of things can cause weakness. So you wonder to yourself, do I have anemia? All right. So you're still on hold with your doctor, right? And you're like, oh, they have this patient portal. Maybe I could log into the patient portal and find out if I've been tested for anemia.
So if you stand here a bit, so we have here a patient portal. It's for Gotham Health. You have an account, so you can go and log in and press the button. It's important that you do these things properly.
Mark, this is not two-factor authentication.
ONC rule is not live yet.
So next we have a login page.
Sorry.
So there's,
I jumped the gun, Mark.
Yeah. So there's a place to put your username and your password, and make sure your password's not upside down, and and after this you now have a user token that you can stick over in this corner there that will represent you on the network that says this person is logged in, I know who they are. So now we have the patient portal, and it's loading. There's no actual data in the patient portal yet. It has to go out and get the data. So I see a section here. So it needs to load allergies first. So network request. Take the portal user token, and let's go over and talk to the proprietary database. And you ask her, does she have any allergies for this patient? Oh, and handshake first, because that's what, all internet Ask her, are there any allergies for this patient? And let's go see what the database has.
Okay, let's see if I have any allergies here. Let's look around. No, I see no information for allergies at all.
So network request, on her back, there is a card that you can pull out. and carry that back over here. And stick it on the board.
With the token.
Oh, and the token as well. We need the token.
Oh, you need the token.
And so, and what you get back is a nice HTML marked up page that says no allergies recorded. Patient, is this useful? Does this answer your question? Yeah, they
Yes, for the folks on the phone.
Okay, right. So you don't have allergies. You might still have anemia. Let's see about what more data we can get. We have lab results next. So let's go do the same thing. Let's grab the same token,
Okay.
and let's see what kind of lab results information
All right.
we have.
The handshake?
The handshake first.
Okay, you're looking for lab results. Let's see. Well, I've got lots of those. How about blood cell genes? Genes? Sure, I've got lots.
And then she has a card again on her back because the API takes all the data and formats it into a nice format that is easy to read in the patient portal.
And your token.
The token, and we put those back here. And now we have. Once he puts it up here, we have some useful information now. It's all HTML formatted. It says temperature 89.7, WBC 7000, whatever that is, and HCT 23%. Does that answer your question? Do you have anemia based on that information?
No, not at all.
Well, you might.
It might, but it doesn't, I don't know the.
Right. As a patient, you don't know how to read this. Right. So this is what you can get out of a patient portal today.
Yep.
And what we're going to do is show an actual patient portal in action. So this is made by a Cerner company. It's for a healthcare system called MedStar Health. They completely run it for MedStar. Basically, we're going to click login. And once we click login, we're going to sign in with a username and password, which is going to bring us to a page here. This is my own health record. It's actually production, but I'm using my own here. You'll notice allergies showed up, and it says no allergies recorded, which was right over there. And it has this concept of latest results. I did it when I needed a physical to get re-credentialed. So they didn't take any blood work. They just did some vital signs on me. So my latest results are from a few years ago. And it's like my vital signs. If you go and look in Chrome DevTools, you'll actually see the network request over here.
It's not a PHI violation if you show your own data.
If you show your own. This is me. Thank you. It's purposely, I consent to myself showing this. So it goes out to that URL, and it gets no allergies recorded, which actually looks like this in HTML, which is what we saw come out there. It does another network request over here, which we're going to click on, and goes to a different URL and gets the latest results, which look like that, and they're all marked up like that in the response. So this is a fairly typical custom API. It's doing some preset network requests, which are returning stuff that's marked up and not very useful to another app developer, useful to the patient portal app itself, but not necessarily to letting other people use that data and make something interesting. So that is the patient portal part. So if your network request 1, you can actually put the hat down and thank you for your help.
Thank you.
Sure. And for the patient portal API, you already took off the vest?
Yeah.
Too heavy. Very heavy vest. So we need some other people here. We need the Fire API, network request 2, the Fire app developer, and provider 1 and 2. Whoa, we're providers today. So this is where it diverged a little from the Health Data Palooza. We'll have everyone go here. Yes. Okay.
Our wardrobe coordinator over there will get everyone seated.
Yes. So we'll start over there, and we'll have everyone intro themselves. You don't need to zip it up. It'll be fine. So what's your name, my friend?
Okay. I'm Aaron.
Aaron. What do you do at CMS?
I help improve outcomes for patients by making it easier for patients to get their data.
Okay, excellent. You seem to be in the right place. I hope you're not just making that up on the fly.
I work on the CMMI program. I am facilitating the adoption of Fire for some of the APMs in 2020.
Great.
I also help with the Blue Button tool for that.
Okay, excellent. So you have you're the Fire API, which is represented by this not so subtle bunch of flames. You also have, if you'll note, you have one cord here because everything is very standardized and there's like one easy way to get data in and out, right? We're going to have you, the API is usually very close to the database. We'll have you go over there. And my friend, what's your name?
Chris?
Chris, what do you do at CMS?
Oh, what I do at CMS? I am a nurse.
You're a nurse? Okay, excellent. You are going to be the app developer today.
Okay.
So we say the app developer is kind of like a wizard because you're going to work some magic. So we have a not so subtle magician's hat, and you have a wand, and please do not hit the button on the wand. Okay, very good. Do you want him right here? Is that good? Okay. What's your name? Ibrahim, what do you do at CMS?
I'm a health insurance specialist.
Health information specialist.
Insurance specialist.
Insurance specialist. Okay, great. And you are going to be provider 2. So we actually have a white coat for you. It's going to subtly represent a provider, and you'll see why in a little bit. It's a little small.
It's a little small. We'll just put one arm.
So when I actually went to get white coats from the break room, I could only find my own that hadn't been used already and one that was really small that hadn't been used. So I apologize. All the others were kind of in use. What's your name? Mary. What do you do at CMS?
I'm all about burn reduction.
Burn reduction.
Burden.
Oh, burden reduction. Oh, okay, so you're my friend. Excellent. Very good. And you are network request number 2, and you have the hard hat because the web is very dangerous place. You'll notice the hat is a different color though, and it is yellow because what is yellow, marked up as yellow, is going to be what the app developer, our friend over there, made today. And what's your name?
Brian,
Brian, and what do you do at CMS?
promoting interoperability.
Promoting, okay, so you're in the right place. Excellent. So
Kevin.
it's a very special white coat.
Sorry, this might be small.
So you are going to be one of the providers. We have 2 providers here today.
There we go.
Here, we need you to look right there. There you go. Excellent. We'll have the 2 providers there. Network request, we're going to need you right there. Okay.
All right.
It's okay.
All right. So in order to build the Have I Been Tested for Anemia Fire app, first, the patient portal where all the data is coming from actually has to know who the app is. And that establishes trust. It makes sure that, the data is going to a place that, the app knows about. So the first thing the app developer is going to do is come over here and register Fire app. So there's a bunch of information that it will need. It'll need the name of the app so that, like an app store, somebody can go find it. So that would be, have I been tested in this case. It needs a redirect URL so that after you've logged in, it knows where to send the patient back to get to your app. And that also helps with security so that other people can't spoof your app. And then it has this thing at the bottom called scopes.
Yep, and what we have up here is actually, if you go to code.cerner.com, and we chose that just because we've done work with this registration portal before. If you go there, you will actually be able to register your own app. And it has an app name, it has the redirect URI, which is once the user authenticates, they get directed there. It has some other stuff, but when we're talking about scopes, there are a bunch of different resources that Brian mentioned earlier that you can authorize your app to use.
Right. So, you can ask for medication information or, appointment scheduling stuff, depending on what you're looking for. In this case, we're asking for basically patient information and then observations. Observations is sort of a catch-all for anything that's been measured by a doctor or a lab or something. Sometimes clinical notes go in there as well. So in this case, though, we're looking for blood counts, and so those will be under observations. So after the app has been registered, you now have a fancy app token that Cerner or whoever else will give you, and you can stick that over in the corner. And that says your app is now certified. And that app token will actually go with the network requests later when we're doing those. So the app developer has now built this fancy app. Have I been tested for anemia? It again has a start button and patient. Let's go. Well, no. The app developer. Oh, sorry. You're a proxy. So it now takes you from the yellow app back to the blue screen. You're back in the authentication for the database where your data is.
Like pretty much the patient portal. It looks very similar to the patient portal.
Right. It's basically the same login screen that's patient portal, except you now also have this app token, and you have this sort of little yellow sidebar. So you're still inside the app context. You've just gone over to the patient portal to log in. Don't give your username and password to any random person on the internet, even if you trust the app. The app doesn't actually know what to do with your username and password. Really, the whole OAuth thing means that you go back to the source of data. They actually know what your password is, and they are able to authenticate it. So after you've put this in, you now get asked this question, which will look familiar for anybody who's used iPhones or, do you authorize the Have I Been Tested app to get personal information and observations? Those are the same scopes. Those are the same scopes that we put in earlier. Now that you've authorized them, you now get an OAuth token that you can stick on the panel over there.
And if any of you have been following ONC lately, they tweeted out about OCR, the Civil Rights, had 5 FAQs about what happened. One of them was about what happens when you hit authorize. If a patient hits authorize, what's the HIPAA obligations of the health system?
If you file CMS, we also tweeted the same.
You did. Steve Posnack, or however you pronounce it.
Yeah.
He like lights up my Twitter all the time.
So if you authorize here, you are now taking responsibility for any PHI that's given back. The hospital no longer is responsible for it. So now we go into the app. And again, like the patient portal, the app has a loading screen. In this case, we're going to use FHIR to go get this data. So now a network request, you will take both tokens, both the one that says who the user is and also who the app is. And let's go over and talk to the FHIR app. And in this case, we're asking specifically for the hematocrit measure, which is ICD code 4544-3.
So recognize who the app is and which patient they've been authorized to access data with.
Yes.
I come over here and just grab
Yeah,
it.
come on in, I'll help you out. So you're looking for hematocrit, there's blood cell count.
Yep.
With that, blood cells.
Great.
There you go.
Yep. So we're going to give you, so they're looking for LOINC
Yes.
4454-3.
Got it.
Which is actually that one.
In my list of values and
And you can actually give it back to the network request.
And the tokens. And then rather than putting it straight here, you actually have a data point. You give it to the app developer. And the app developer is going to... Yes, well, tokens can go back there. The app developer takes the red blood cell, and he picks up the card that's over there in the corner, hidden, and does some magic, does some business rules and calculations, and you can place that over here. And for those on the phone, when the thing sticks, it says, your blood counts were low 2 months ago, 23%. This may be why you're feeling weak.
Magic. You can actually press the button now if you want.
If you want to press
On the wand.
if you want to press the button on the wand, you can do that.
Oh, this.
So now this suggests not only do we now know you might have anemia, your blood counts are low, but we can actually send some of your data off to providers, and they can evaluate your condition and maybe offer treatment options. So for the purpose of this demo, we're actually going to send the data off to a couple of different FHIR endpoints, and we will get estimates for what a care plan might look like for that particular condition. So you already did, yes, you're very efficient. And let's go make some more FHIR calls. So first thing we need is the network request. Let's go get a lot more data for this patient. We can get, yeah, same thing. So we can get observations. We've given access to all the observations. So let's go get more observations for this patient that we can then help the providers make their decisions.
You're so well authorized, I'm going to give you
Now, we have two providers in there. So show each of them this bundle of information, and then each of them will write down how much they think it will cost to treat this particular condition on your little whiteboard. That's supposed to look okay. That's supposed to look during guys across the country, you know, like e-visits, telehealth. What's in that box matters a lot. You want to be very custom for this patient, obviously.
All right. Have you committed to a price?
Price is right.
So is it the negotiated price with the health? The actual cash price that somebody would pay out of pocket?
It's probably Cadillac here.
Cadillac care?
We knew this would
Concierge.
spark some discussion, so we added it.
That's why it just made my thought.
All right. Are you providers done there?
His writing is illegible.
Oh.
That's good.
Really big letters. Really big letters. Has to show up on video.
How much it would cost, okay? Sorry, network request.
All right. And the network request comes back with all of the data, and I will help you stick these things on. And here we go. And so So patient. We now have some answers. Do you like either of those? If you want to talk to one of these doctors, you can go ahead and book an appointment with their system, also using FHIR's appointment APIs.
Can I go Google another price?
And on the camera, this one says a lot. Do you have an HSA more than $1,000? And that one says a whole bunch of things and $1,500. Book appointment. All right, sold.
Excellent. Magic, right? All right. So we do have.
You can sit down now if you would like.
Yeah,
Make
yeah,
sure
sit
we're
down.
going to take off the garb.
Yep.
Patient, put your robe back on. We need pictures.
Oh.
You have to promise it will not be on the internet.
I'll do my best.
Oh, yeah.
We'll send this to.
Oh, Kevin. Oh, Kevin. Or Brian. John has a
Yeah,
question.
we still have more.
Questions now, or?
Well,
Or we could do that.
Send someone in?
yeah.
Writers?
Wait a minute. I just want to do
I guess they want you to-
All right.
Just got a couple folks in there.
Yeah. A few folks in there.
Thanks.
Golden
Thank
ticket.
you.
Very well distributed. I like it. All right.
Thank you.
Excellent. Okay, so we actually made an app like this using Cerner's live developmental sandbox. Cerner's sandbox is actually the same. If it works in the Cerner sandbox, it works in production, it works in a build environment, it works in all the different environments. So once you make it there, it actually works in production EHRs. And that's how we built the apps that we use at MedStar for one of them. So you go and you click Start, and if you'll remember, there was a username password that showed up that looked like the patient portal. Oh boy. All right, you're gonna get an authorizations screen for Wilma Smart, who's the person we're logging in as. And there you go, you got your blood counts were low 2 months ago, which looks very similar. We're gonna look at some of the network requests right now. It went to that at sandboxcerner.com. And it got back some JSON, if you guys are familiar with JSON. To give you an idea of what gets returned, there's an address that was returned, and you know it's Cerner because it's Kansas City, is the sample patient's address. It also has their birth date. It has their gender. It has their name official, including maiden name under there. It also has some phone numbers and email addresses, wilmasmart@gmail, which is really interesting. This was the network request to observation. There was a token, that big gobbledygook up there. It asked for LOINC code 4544-3. This patient actually had 2 of those hematocrits. This is one of them. I showed you in the JSON that there is a code in LOINC for hematocrit right there. There's an effective date time when it got done. There is also an interpretation, which in this case, that hematocrit is low. There is the quantity, so the value of 23, which is what you see up there, 23%. If you're curious about these tokens, you can actually take one, copy it, and paste it in something like jwt.io, which is a website like this. And if you take that gobbledygook and paste it right there, you will see that it shows you on the right side the patient identifier and the patient scopes. It was patient read and observation read. So if we click yes to get more data to send it to the providers, what you'll see happen is a bunch of other network requests go out to observation. I think the observation resource returns 10 at a time by default. So it's actually going to scroll through a whole lot. We fast forward a little here. And it got a bunch of observations that it then shipped to that estimates API down there, which is somewhere at Amazon, like AWS something or another, execute API US East 1. It sent it in its request payload down there, all those observations over to Wire in real time, the same stuff we were looking at in the last ones. And it got the bids back. In this case, we got 908 and 979. So that was it passing all that data to a third-party provider API and getting a bunch of bids, which it then stuck up to here, which is very similar to what we had over there. So implications.
Great. So what we were hoping to do today was kind of highlight what's already available out there, right? So patient portals already exist. The FHIR resources are available already. There are app developers out there that are creating new and interesting applications using the FHIR resources. But unfortunately, not all app developers are good wizards. There are some Voldemorts out there kind of lurking. And so just a couple of things to keep in mind. Does a patient give more access to more data than is needed? If you remember on the Have I Been Tested app, the patient authorized the app to use the person resource and the observation resource. So if you actually look at the person resource, the information included, which Kevin kind of went through already, includes the next slide. So it has your date of birth, it has your address, it has your phone number, right? The app didn't show you that on the front end, but since you already gave access, they can actually access that while using the app. The other thing to keep in mind is a patient could give an app offline token permission, meaning that the app can have persistent connection with actual patient data. So the patient doesn't even have to click authorize every time. It can actually just query Cerner, for example, and get information. So I think one of the things that, a big question that we still face today is how do you know which app to trust? That's certainly something that we still struggle with at MedStar Health. But despite all that, we think that this technology has a lot of opportunities for the future. So I turn it
Sure,
over to
right, and to echo Christine's point, there are always bad wizards out there, but one of the things that we're very excited about with FHIR is that app developers like us can work with CMS and work with providers and build an ecosystem of apps that can help patients. And so I think that's truly the promise of FHIR and why we're so excited about it. The fact that we can take raw and unstructured data and exchange it and build new functionality with it.
Great. So that is Let's Make a FHIR App with You, and this was a wildcard talk, so something really experimental. This is the second time we've ever done it. So thank you everyone for participating today and getting up and being patient and network requests and putting on hard hats. That's all we got. I don't know if we have time for QA. That's up to you, Lorraine. I think we do.
Yeah, I think we do. I'm going to check and see if Viet is on the line, then he can start. But let's open it up to questions. I know John had one. I don't know if others do also. John, go ahead. And then I have one.
I'm just trying to understand a little bit about the operating model that this works in. And so in the examples where you have specific FHIR, APIs that have been developed to address specific questions, and then those get deployed somewhere that are publicly available, I guess. And then each entity, whether, like, if you're MedStar and you have partnered with Cerner to say, I know when I go to Cerner, this is where the data is, or somehow Cerner said, if you come in with such a request, we are prepared to handle this kind of question. So when you come in, we know, because that question has been posted, it's something that we wanted to support as maybe an EHR vendor. And so I was just trying to get in my own mind the relationships and the partnerships between, say, like an EHR like Cerner and these FHIR applications that are being built. And then the next part of that question is, then when I say I want to shop for a doctor, is it my assumption that there are doctors out there who are also willing to entertain those questions, and they have to have been made available, or somehow there's an ecosystem where they say, I want to be able to accept these kinds of questions so that I can bid for work. And that's how I think of it in my head. I'm not sure if I'm thinking of it correctly or not.
So I think a lot of this is coming from 21st Century Cures, which says, if you're an EHR, you got to have these APIs in, right? And ONC's draft proposal specifies what data is going to be in there, right? You got to have observation resource, you got to have document reference, and you're not supposed to information block. Like pretty much what is back there, what is in that database of plushy toys should be available to that patient from these resources that are specified. I think they're called USCDI, and it comes out via Arch or something like that. So it's not necessarily that, Banner or some other health system tells Cerner, hey, we want this API. A lot of what's going on is trying to meet these regulatory requirements that you got to have observations that are able to come out. Okay. You got to have patients. You got to have document reference, and I think diagnoses and conditions and stuff like that.
I mean, I think your question is very valid about access, though, because it's not just a matter of, so in the consumer space with the Apple App Store, for instance, the developer makes the app, submits it to the store, Apple gives some, cursory level of validation, and then it's out for the public. So now with Fire, the EHR vendor has to decide what level of support it wants to make available. The health system might have to upgrade the EHR to get to that level of support. And then each of the vendors that are building these apps has to have validation from both the EHR and the health system. And so there's still hurdles to get to.
And just real quick, and your point earlier about the Voldemorts that are out there, if I'm a vendor and I want to develop that, I think what you're implying is there's got to be like some type of accreditation, or if there's not, I could theoretically siphon that, even though I permitted that person to grab my information, could I siphon it off for my own purposes, like Facebook and Google and everybody else does when you use their product?
What's going on in Google Maps?
What's happening under the covers? They're using that data to build profiles. So is that what you were alluding to?
Sure,
that's kind of the challenge.
A lot of the vetting process is around making sure that your vendors have the standard accreditations that we would expect. So are they HIPAA compliant with things? Do they handle PHI in the right way?
Got it. Okay.
Although I will say from the OCR rules that came out recently, and I'm not a lawyer or whatnot, basically they were saying that you got to let any app connect, right? That is information blocking, is that I'm a patient, I have this app by Voldemort Company and friends, and I want to connect it to the electronic health record to get my data out. I think the final rule when it comes out, probably, sometime at the end of the year or early next year from ONC, will specify a little more stringently as to, is there a mechanism to not let that obviously bad app not access that data. But from reading the OCR stuff and from reading what I see out there now, pretty much everything is going to be, any app can connect. If you're a patient and want to bring any app that you're choosing, you can connect. Epic has set their shop up in such a way that the health system doesn't approve any particular app once they're in that developer portal, and they do that whole 3 thing where we have the app developer put 3 things here. Mm-hmm. Once they do that, they can do like a little background check and make sure that company exists. And then you just whitelist it, and it's able to access EHR stuff.
And each EHR right now is sort of setting up their own app stores. Some are more far along that process than others. I don't know, or from our perspective, that is a sort of regulated space yet. It may be beneficial for that, in the future to have some more standards around what is a trusted app. Currently, the EHRs are sort of inventing this.
And there's different types. Like if you have a provider app that a healthcare system is buying, then like Cerner will go and vet it and all that stuff. Although according to ONC rules, I don't think they necessarily need to. For patient stuff, my read of it is that anything can connect, like that the patient wants to use. It's their data, Yeah. But I think when the final rule actually comes out and what the disincentive for, because part of this is data blocking, what the disincentive for providers versus EHR companies is.
And there's actually 2 different interesting cases there too. One is patients who are also developers who want to get access to their own data so they can do whatever. I've seen some pretty incredible apps, like by, for example, a cancer patient who went and got his data through Fire and then was able to graph his own data. That's also, though, a different level than you want to build an app that other people use and they entrust their data with your app. And those may actually need to be handled a bit differently, perhaps in the future.
Another question?
Hey there.
Go ahead, please.
Question from the phone when you have a second.
Yeah.
I was just going to share, I've worked with Fire for a long time. A lot of connectathon work around creating trust mechanisms that enable enable scalable trust, not just for access, but also to be able to write back to the EMR, which is certainly the next step that we want to take. Above this, Lorraine, maybe we do another session like this, just talking about that scalable trust mechanism that we started developing with our friends at CMI and the Blue Button 2.0 program, looking at how do we eliminate some of these unfortunate silos that are emerging around app orchards and EMR vendors becoming sort of de facto certifiers of OK programs and some of the things that are unintended as a result of that. So maybe next quarter or whenever we can come in and do that for you.
Sure. Well, and part of the reason why Asymmetric, for instance, builds a server, an open source FHIR server, is to kind of take the EMRs out of the loop a little bit and so allow providers to build their own platforms that can be accessed by developers.
One of the unfortunate consequences of having all of these independent entities sort of certifying apps is that you end up as an app developer having to get certified by every data holder, which really stifles innovation and adoption. So we want to kind of break through that by building a platform that enables trustworthy entities to endorse applications. And it may be specific to access, which would have a very low bar, like what Epic is doing today. But when we start talking about a beneficiary trying to get disability determination through SSI, there's going to be different certification requirements to that. So a scalable framework that's flexible that can handle those kind of use cases will be an important part of a broader adoption for consumers.
And then I guess
A question on
we
the
have one more
phone.
time for one more question on the phone.
Hey there. This is Carl Davis working on the CMS Blue Button. I just echoing what I think Aaron was saying there, is this is actually a problem that CMS itself faces right now in determining which applications we allow access to the CMS Blue Button API. And we're spending, at least I'm spending a lot of time thinking about how that problem morphs from a problem that CMS has right now to being a problem that all of the payers have and all of the applications that are looking to work with payers have if and when the new interoperability rule goes into effect. And instead of having one Blue Button API, you've now got dozens. How do I, as an application developer, ensure that I can actually get my application deployed across the industry without, literally having to pay people full-time to work on application approvals for a year or two to get through that hurdle? It's an interesting and rapidly evolving space.
Stay tuned.
Thank you.
I just have one other comment, and it's something that you guys didn't bring up, is that it's incumbent upon that patient to read the terms of service and the privacy policy. And I know we're all really bad at going, accept, but just like you said, like what's under the covers, you want to know who they're sharing your data with, how they plan to use it, to make sure they're not going to resell it. All of those things are so important, and I think it's really incumbent upon those of us that are reviewing terms of services and privacy policies and looking at all these apps that are coming knocking at your door. You don't want to dissuade them, but you want to make sure that your Medicare beneficiary is taken care of, and that they really understand they need to read it and understand where their data's going.
Well, and what we saw was that the scopes are actually not very restrictive, right? That you have access to patient data, you have access to all of their demographic data. If you have observations, you can get HIV tests, and you can get, cancer screenings, you can get, perhaps mental health tests or things that might be in the observations table. And at the moment, there isn't really a good way to prevent that through the FHIR API itself, except the server could potentially put their own things in place to prevent that. But yeah.
Yeah, and I totally agree with what you're saying, that you need to read the rules, but not all patients, if you want that data, if you're a patient and you want that data, you can't move forward unless you accept that.
Right.
And that is a big problem as well. And not everybody has the health literacy or the IT knowledge in order to understand.
In the best of all worlds, this trust mechanism that we're thinking about would enable a not-for-profit organization or somebody who's very privacy-oriented to endorse apps and say, hey, this app meets or exceeds Karen Alliance's potential, others. You would expect consumers to be able to say, oh, I trust the Karen Alliance to have vetted this app's privacy policies to make me comfortable, rather than reading 45 pages of my privacy policy.
Which is better protection than exists for a lot of apps out there now. Don't touch healthcare. Yeah.
No question about it. The upside to this is, orders of magnitude greater than the potential risks, in my opinion.
Great.
Any other questions? Well, Kevin and Andrew, Brian and Christine, thank you so much for your willingness to come here and join us. You're welcome to stay and hear Viet. I think I saw or noticed that Viet joined the call. Is that,
Yes, I am.
is that true?
Said yes.
Okay, good.
Yeah.
Thank you. Hope Atlanta is nice.
It is nice. It's warm but not humid, which is a lot to say about Atlanta.
Yeah, I'll say.
Nice to be able to say about Atlanta.
Yeah, we'd like to be able to say that about Baltimore as well.
Are you able to see my screen?
We can.
Okay, and when I go to presentation, let me know if you can still see my screen.
Yep.
Yes.
Okay, great.
All right. So can I give you like a brief, quick introduction to, just to let people know who you are, and then
Sure.
we'll let you launch just
Great.
quickly. All right. Thanks for hanging with us. Now you're in for another treat. Viet will not be dressing you up or giving you golden tickets. But we are very fortunate. Viet is an internist. Many of you, or some of you probably know him. Internist, pediatrician, and clinical informaticist, if I pronounce that properly, with over 15 years of experience. I think he is very well known in the fire space. And has been working on interoperability for quite some time. He is formerly a CMIO with Lockheed Martin and has been doing a lot of education. I think he's probably very hotly in demand right about now because of all the work going on with HL7 fire. He's very involved in a lot of the Da Vinci projects, so any of you working on some of those probably have seen his name on some of those work groups. And I asked if he would give us an overview. I had a very, very long list. We've had to cut it down on fire and the implications for us at CMS. So this is going to be kind of speed dating related to fire and the implications for a broad spectrum of CMS projects. So I cannot thank you enough for joining us from the Atlanta program. We'll try not to take you away for too long. And with that, I will give it back to you.
All right. Well, thank you, Lorraine, for inviting me. I'm happy to follow up if there are additional questions, and there always are in the future. So my hope for this discussion is to give the folks on the call kind of a baseline of understanding of fire, because in every group that I've had these conversations, we have varied expertise, from people understanding the acronym all the way to folks who have developed applications. So I want to help your group kind of level set with the terminology and understanding of fire so that you can have good conversations and really get engaged. So hopefully I can skip this one, and you all appreciate the importance of interoperability. And for me, I think with the emergence and evolution of our health IT and healthcare ecosystem moving towards value-based care, interoperability is becoming even more important, as we need to share data across the continuum of care, from acute to post-acute and back to primary care. So this slide is called Why Fire, because back 7 years ago when we started talking about this, people always asked about why fire. But I think there's been a evolution in understanding about fire, and it used to be what's fire, and then it's why fire, and now hopefully with this group you're going to start asking me how fire. So how can we do this with fire? So the idea here with fire is that in 2011 the board of HL7 stepped back a little bit and did what they called the fresh look, and asked what would a modern interoperability standard in healthcare look like. And they asked several of the leaders within HL7, Graham Grieve in particular, to look at what was happening in the IT ecosystem outside of healthcare and come back and give some advice. And so what came out of it was the notion of using APIs and
RESTful approach to data exchange, and that became the core of FHIR. And it was just this recognition that we're going to need to share data not only from clinicians and to payers, but to other data users like public health. And so we needed a fresh look, and that's where FHIR came together. So just to highlight early on here some of the benefits of FHIR compared to the previous standards that we have. It's really very approachable for experienced developers. I teach a FHIR practicum at the University of Utah, and I also mentor with Georgia Tech groups of computer science students, and they pick up FHIR really fast because it's technology they're already very familiar with. And FHIR supports these predefined resources, so when people want to start and create an application, I strongly recommend that they don't try to develop their own data models. I ask them, look at FHIR first, and because it supports the vast majority of the healthcare data we're using today, and it's extensible, so it allows you to add your own data elements as you need. There are lots of documentation around FHIR, and the FHIR spec is open sourced through HL7, and unlike previous standards, we have a ton of reference implementations and code bases for developers to pick up and use FHIR right away. And another benefit is that validation of FHIR, like the resources that I'm going to describe to you and the operations, are built into FHIR. So you can check to make sure that the data that you create or you retrieve is valid data. We also have a very active implementer community. We have some folks on the line. Could we ask folks to please mute and unless you're asking a question? Thank you. We have an active implementation community, and so that implementation community is two sides of the standards coin, where they take the standard, implement it, find the gaps in the standard, and then feed that back to the HL7 standards community to improve the standard. And that's done through the use case work that we do in DaVinci and other projects, as well as connectathons, which is an important aspect of FHIR. We also have open source code libraries from Happy to .NET to C, so you can download these open source code sets and create your own FHIR servers and get developing very, very quickly. For clinicians, we encourage clinicians to get involved in the design of FHIR, to test the resources, to help develop use cases so we can make sure that the resources that are created support the workflow. There's tooling available to help teach informaticists about how FHIR works, and that's part of the education we do in HL7. And we're looking to expand the reach of what we can capture in FHIR around genomics and other domains. And so it's a base part of FHIR, and the resources are fairly mature, but we're growing as we discover more and more things. It's the how FHIR part of the question that is helping us realize that we need to expand this work to include other domains. For consumers, there's already evidence, and fortunately from CMS with the blue button, that patients can benefit from FHIR because they can get, using these standard APIs, companies can develop their own applications and be able to allow patients to get to their clinical data and claims data more securely. So I think that's important in getting patients engaged in their own healthcare. For healthcare organizations, it's important to note that through the programs like the Argonaut project, the major EHR vendors are on board and have implemented FHIR, and I'll show you an example of that and why that's important to this conversation. But we have tons of vendors that are also implementing FHIR, and so this whole ecosystem around interoperability is growing, and the expertise is growing, which will then lead to faster deployment of FHIR and FHIR APIs, and then really go to the next level where we can add additional value around analytics, decision support, and population management using FHIR data. So I put this at the beginning of the deck because in case there are any skeptics and wondering, do I really need to learn about FHIR now, or can I hold off? So this slide and these two graphics were borrowed from the ONC, actually, when they presented this early in the year and showed on the left that 87% of hospitals in the U.S. have EHR that are certified on Fire Release 2, and that 57% of clinicians in the U.S. have EHRs that can use Fire. So there's always that chicken and egg question: is if I build something, will anybody use it? And I can firmly say the answer would be yes. Additional kind of proof points around this is that there are this is about a month-old data, but there's 287 health institutions that have endpoints for Epic that support Fire. There are 1,200 combination of institutions and providers on the Cerner platform that have Fire endpoints. And last fall, Amazon, Microsoft, Google, and others signed an agreement to use Fire as their baseline data model for sharing data, healthcare data in their APIs. And if you want additional evidence, you could, if you happen to have an iPhone in your pocket, you could open up the Health Kit, which is an app on the iOS system, and be able to identify, based on your location or a zip code, any health systems near you that have a Fire endpoint. And why this is important is that Apple went to hospital systems and said, do you want to be on, our Health Kit? And they took some of the leading healthcare organizations, and they wanted to be early adopters. But in order to be an early adopter, Apple said, okay, you have to work with your EHR vendor and make sure that your Fire endpoint is 100% compatible with the Argonaut implementation guide, because we're not going to design point-to-point integration with you in our Health Kit. And by getting the hospital systems and their EHRs to adopt that DSTU Argonaut implementation guide, they could then be on this Health Kit and share their data to their patients. And the beauty of this is, you look, they're the basic allergies and immunizations and lab results, but you could actually use your personal patient login to the health system portal, download this information, and actually see what it looks like in Fire. And I think that, given how many people carry an iPhone around, this is a pretty significant demonstration of the scalability of these Fire resources and implementations. So this is more evidence that I think it's a good to get on the bandwagon with Fire. So I'm going to switch gears and give you some basics of Fire so that you can be able to follow along and contribute to a conversation around Fire.
Hey,
so one of the, yes?
Mark, go ahead. Mark, I think Mark either had a question or...
I think he was asking if we could mute.
Yeah.
Background.
Right. I think some people can hear a lot of background noise, so we just wanted to reiterate if they can, and I think you did too, to mute their phones again.
Yeah, this is Mark. We're hearing a lot of background noise and a lot of clicking on our end. So if there is any way we can minimize that, that would be great. Thank you.
Yeah, thanks for bringing it up. Sorry, yeah.
So, no problem. So these are a handful of what we've called the Fire manifestos. They're more high-level guiding principles and not strict. But the key thing with Fire is that it's very implementer-focused. And we want implementers to try out Fire and really help make the standard better. They focus on the 80% rule, which, depending on who you talk to, could be 80% of functionality in the EHR or 80% of kind of activities that clinicians conduct their care in. So we have this 80-20 rule. We want to use today's web technologies around APIs and RESTful services. There should always be a human readability aspect, so any of these resources, when they're in production, should be human readable and computable. And we really focus on being paradigm and architecturally agnostic. The standards part of Fire doesn't focus on architecture. We leave that to the implementation community to decide the best approach for architecture, and if architecture has implementations on the standard, then we add that aspect to the standard. And the Fire implementation guides are all open source. Okay. Hang on just a second. All right, let's see if that works. Uh-oh. Okay. I'm going to skip this slide for now. So FIRE is related to other standards because we've learned from version 2 and the challenges around point-to-point integration with IT systems. We learned from version 3, which was beautiful in that it could model everything, but the challenge was that it was so flexible that the implementation varied quite a bit, and it was actually very complicated to learn version 3. My first time with a CDA, it probably took me 2 weeks of sorting through implementation guides to write my first valid CDA document. But in our tutorials that we give on FIRE, and I'm giving one this afternoon here at AMIA, and we do it at the working group meetings, we can teach an individual how to create a valid FIRE resource in under 5 minutes, and we can validate it. So the speed of learning how it works and creating valid resources is very quick. It's been adopted, and we have work groups in HL7 like CIMI, the Clinical Information Modeling Initiative, creating standard FIRE observations. We have groups like IHE doing implementations. FIRE supports DICOM and imaging within the resources. And the core to a lot of FIRE is the use of standardized terminology so that the data that we share is computable. This is a relatively new diagram. Actually, I just got it this morning from Dr. Chuck Jaffe, which shows kind of the timeline around FIRE and how it started on the left with that fresh look. And then the JSON task force was formed and recommended the use of open APIs, which led to the formation of the Argonaut project, the requirements around the open APIs through ONC, and then the big one was last year and Apple's announcement of the Health Kit. I think that really accelerated people's recognition of the FIRE as a real thing and not just in the prototype. The Da Vinci project was formed just over a year ago. We've done quite a bit of work, and I have some at the end of this talk, but if we run out of time, I'm happy to come back and talk about Da Vinci in the future. We have the cloud vendor commitments, as I showed earlier, from Apple and Google, and in December of last year, we had the first version of FIRE, the R4 version, that went normative. And one thing that's important to note about FIRE is that unlike past versions where you stamp the entire version, we have a FIRE maturity model. When we add new resources, they go through their paces in terms of connectathons and implementations, and when they prove that they're stable and they work, they become normative. And the importance of normative for the health IT community is that you won't have breaking changes. That going forward, that version is going to be supported of the resource that is. And the ONC and the CMS NPRMs in March really accelerated people's timeline and really brought recognition to the importance of FIRE to the whole health IT ecosystem. So folks right now are vigorously reviewing the NPRM and providing their responses. But I think this is the regulations will actually drive a lot of this adoption. So where can you use FIRE? So FIRE is think of the interoperability standards as just these operations or APIs and the resources. So they can work in many different paradigms. You can create applications that work against FIRE, a FIRE server like the Happy server, or you could create server-side applications like clinical decision support, and you can use FIRE as a broker. And we're in Da Vinci, we're bringing in some of the HIE vendors and the community to see where FIRE fits into the ecosystem that exists today. And so there's many different ways you can use FIRE, both on the client side as well as on the server side. The specification, this is a screenshot of the top part of the specification you can find at hl7.org/FIRE. And essentially it's divided up into 5 levels, with the level 1 and 2 are the most basic aspects, the foundation level, how do you structure FIRE resources so that they're computable. Level 3 talks about how you do patient administration type resources. Level 4 are a lot of the clinical workflow and financial resources around FIRE. And then level 5, where we're having emerging work, especially with CCSQ and the quality measure work, where we're bringing together all those aspects of FIRE and adding additional things like clinical decision support and the clinical quality language so that you can not only exchange data, but leverage that data and compute on it. So the first thing when we talk about FIRE is that I want you to understand the notion of resources, capital R resources. And a FHIR resource is really just a content model. It's what's being exchanged in the API, whether it's a patient resource or a practitioner resource or a medication request resource. And that's what's shared between in the API. So I can search for a resource and retrieve it, and the server sends it back to me. And these resources are informed by previous work in version 2 and version 3 and other standards communities. So number one, resources are the content model. And these are a list of some of these resources. You can see on the left are common clinical resources like conditions, family history, allergies, all the way to diagnostic resources around observations like a hemoglobin A1C or a CBC, all the way to a diagnostic report like an imaging study. Medications is a complicated domain, and so it actually has a handful of different resources that represent the different aspects of representing a medication to a medication order to a dispense and an administration. So these are, when we talk about resources, these are what we're talking about. And each of these resources, if we look on the spec, you would see that there's a number next to them, and that represents the maturity of them. And if it has an N next to it, it means that it's a gone normative. So I know you can't read this, so don't try. But the notion here is that with every resource, we have metadata that goes with it that tells you when it was created or updated. There's a human readable aspect to it so that if you didn't, you can't read the coding, you can still know what the resource is trying to tell you. And you have the notion of extending resources if you're adding more data elements to the resource. And then you have standard data types. And I'll talk a little bit about some of the coded data in a minute. So there's structure. And the idea here with these resources, FHIR doesn't have a traditional data model like we do with other models. What we do is the resources reference one another. So, for example, if a patient has had a procedure, let's say a colonoscopy, that procedure resource has a reference to a subject, which would be the patient resource. It has a related item, which is the condition why the procedure was done. It has a report that it points to the diagnostic report for the procedure, and you could tie in who the performer was as a practitioner resource. So what happens is FHIR creates a web of data that links resources together based on the resource data models. So, for example, we have a simple example here of a 12-year-old boy who has pain in the right ear, elevated temperature, on exam has an inflamed ear, diagnosed with otitis media, and prescribed amoxicillin. In this example, you could represent the pain as a condition, the elevated temperature as an observation, the temperature itself as an observation, the physical exam finding as an observation, a diagnosis as a condition resource, and then the amoxicillin as a medication or medication dispense, depending on how you want to do it. And then the patient comes back, and well, that first episode of the first consultation would be an encounter. And then in the follow-up, you would represent similar elements of the history with those same resources. And you would add the allergy. If the patient had an allergic reaction, you would add an allergy intolerance resource. So this is just showing you how the data links through these various, what we call references in the data model. So structured data is really important to the resource, and that allows you to make this information computable. And we have different kinds of coded data in the resource. So here's an example of the patient resource, and this is called the structure view of the resource. So we have the elements on the left-hand side. We have cardinality and flags for developers. And so the cardinality is important because, of course, it determines whether or not the data is required or not when it's being reported. But we have these different data types. You have the identifier data type, a Boolean, which are kind of very basic data types. And we have complex data types like address. And then we have, really importantly, are these codable concepts as a data type. And these codable concepts are then defined by a set of terminology. For something simple as gender, we use HL7's administrative gender, and we have 4 possible values for this particular code set. And the other important thing that we do as part of the definition of the resource in the background is that we tie this code set to this data type to a specific code set, and under the covers, you can actually check this code set against the NLM VSAC, or the vocabulary.
Value Set Authority.
Thank you, Value Set Authority Center. And so this, again, is computable and can be validated. So if you were to save a resource for gender that was, widget, it could be tested, and you could confirm that it didn't fit this value, this administrative gender, and you can reject it or you can correct it before it ever gets saved. So that's really really important in terms of being able to maintain good data quality. So as part of a FHIR server, you can do three things. One, you can save data as you would any kind of database, and it supports both SQL and non-SQL databases, but you can also serve up terminology. So FHIR supports basic terminology, meaning if I have a code, I can give you the fully specified name. If I have a code that has a hierarchy like SNOMED, I could give you all the children. I could build a value set for the code set. When you want to do more complex terminology work, you would typically get a production terminology services from a vendor company. But the value here is that you can represent everything from a code to a value set, and also leverage the knowledge in the hierarchy, such as what's available in SNOMED. So it's very valuable. The other aspect of a resource is that it's that 80-20 rule. It supports 80% of what we think people need as represented by the data elements, but we recognize that there are situations where you need more data elements, or you don't need to use all the data elements. So what FHIR allows you to do is called profiling, and profiling allows you to either constrain down each element. So instead of saying 0 to many, I might say 0 to 1. Or I could say 0 to 0 and eliminate the element completely. Or I can make do 0. I can make 1 to 1 and make that element required. And where it's best demonstrated in FHIR today is what Argonaut did with the U.S. core profiles. In the U.S., we through legislation require recording a patient's race and ethnicity. Well, FHIR is an international standard, and other countries don't use race and ethnicity. So the Argonauts took that requirement and added an extension into the patient resource definition, and added race and ethnicity so that we could store that in the resource model or the profile model. So when you use U.S. core, that's an example of why it's U.S. core and not some other country's core set of data elements. And U.S. core has been adopted by ONC as well as part of the U.S. Common Data for Interoperability. So this is another example of a profile where you might define that here for an identifier might be this is taken from the NHS, might be a specific NHS number. So we in DaVinci have looked at the the coverage resource that has an element for subscriber, and we said we want that to be the subscriber ID of the payer. So we created a profile to constrain that down because it was important enough in the exchange of information with a payer. So that's where profiling would work. So with profiling, everything is stored as what's called a structured definition, and that structured definition is just a way of representing what you see here in a computable form that lays out the data elements, these cardinalities, the data types, and then if it's bound to a certain vocabulary, where you would find that vocabulary. So everything in FHIR, all the FHIR resources have a structured definition, even the base resources. So another important aspect of FHIR is that it supports not only the future using REST, but also is backwards compatible in that we can support documents, messages, and we can support these the kind of an API approach to data exchange. So a collection of data that's sent through FHIR is sent as what we call a bundle, and that bundle is a container. And in that container, we can define what the resources are that are inside the container based on the context that you create the container. And you can reference individual resources, and the resources inside the container can reference each other. But that bundle can then support the REST approach, where you can query and retrieve data in a normal kind of CRUD approach, and that's pretty common. And then it can also support the use of APIs. And so I want to take a quick, brief detour on APIs, because in the past we use the term a lot, and I just want to, for those who are unfamiliar with APIs, give you some real-world examples. An API it stands for an Application Programming Interface, and the idea is that the interface collects some data. When you enter or submit that data to a server, the server knows the context where the data was collected, and then performs some operations on that data, and then returns it to you. So a common one would be Expedia or one of the travel sites. You put in your origin, your destination, the date of departure, date of return, and the number of travelers, and you click search. That data, each of those data elements is represented by a data model that's sent back via an API, that search API, back to Expedia, and Expedia in their background takes that information, searches across all the airlines that they work with, and using the airlines APIs, and then gets back a bunch of information. Then they take that information and they display it for you. And those same APIs or similar APIs or collection of APIs can help you then book that flight. It can help you pay for it with a specific credit card, and then add on to your itinerary with hotels and cars. So I've always liked the notion of transforming healthcare's ecosystem into much like the travel ecosystem. In the past, you had to use a travel office who contacted each of these vendors to arrange your itinerary, and they'd send you the itinerary as a static document. But anyone who travels knows that flights get canceled and planes get changed. But that static document, you don't know that. But in the modern API era, if a flight gets canceled or delayed, you get a notice from your Expedia app, or for me, my Delta app, or some other airline's app, and that could only be possible with these APIs. And so if you imagine a patient is now a traveler, the traveler becomes the patient. Instead of having an itinerary, you could have a care plan, and instead of having a hotel or a car rental, you would have a hospital or a home health. And the data that's exchanged between each of these entities on behalf of the patient is all based on FHIR. And that way you can kind of both monitor and update the activities that are happening on the patient based on who needs to know. And for example, a hotel doesn't have to expose how they manage their housekeeping and turnover of their rooms, but they would probably want to expose their API to show that room availability or when a room is cleaned, so that they can inform the traveler or another platform of this information. So APIs are really changing how we interact with data and business processes. So FHIR also supports documents, so you can represent CDA information in FHIR, as well as take CDA information and represent it as FHIR resources. So that allows for an opportunity for some backwards compatibility, as well as to not lose the investment that's been made on CDA. And CDA is essentially another kind of document as a bundle. It's a composition resource which you can store CDA aspects like who the attesters are, the sections that can be coded as LOINC codes, and then you put the data just like you would as entry in CDA as observations or lists or conditions. So there's a fairly good parallel, and there are vendors who have tooling to do this conversion from CDA to FHIR. CDA also supports messaging, and we have lots of messaging going around today, so the ability to do alerting and to send like lab messages. You know, labs are often use version 2. Well, we can still support that through FHIR. And it would be, again, another kind of bundle. And then FHIR, along with resources, is the need to understand that the API are the operation. So there are simple operations that create, update, retrieve, but you can also have complex server-side operations. And where you take that, just like the Expedia example, you take the traveler information and you process that, you parse it out, and you send the query to a whole bunch of different airlines. We can do the same thing in fire by defining an operation. The one I'm familiar with is we're working on this quality measure. We have the ability to submit medication reconciliation from a provider to a payer, and we submit all the supporting information. We don't actually write anything to a payer's database. We just provide that data via the API, and the payer can then take the resources and parse it out the way they want. They might store the original fire data, but they don't have to because we're not doing the traditional CRUD operation. So operations are really powerful because you can make more complex operations depending on the need. And some of the basic operations are as I mentioned, the CRUD operations, but you could, there's search operations, and every resource has a list of operations that support it when you go to read the specification. So fire is really, as I mentioned before, it's paradigm architecture agnostic. You might send messages via fire, or you could interact with a fire repository using REST, or you could take the data in a fire repository and create documents. And ultimately, the idea here is to create a fire ecosystem, much like that travel ecosystem, where you have data, store data in fire. You can test conformance using fire. You can use terminology, standardized terminology within fire. You can use the data elements and using fire-aligned technologies like CDS hooks and Smart on Fire to implement decision support using fire. There are resources to manage workflow using fire, a resource called Task. And why that's important is that we used to think that that interoperability is just exchanging data, but that data is being exchanged because it's part of a process. So as a physician, when I order a lab, I'm making a request to a lab to obtain the specimen, do the test, and then respond with the results. Well, that's a workflow. And so we can represent workflow in fire, and that's still fairly new and emerging perspective on interoperability. Some emerging things that are really important that we're recognizing is the need for a directory of services, pharmacy services or consulting services, and even directories of individuals, like who is a Medicare provider. So we want to be able to make that readily available through fire resources. Or if a patient has a formulary, what are the formulary medications? We can expose that using fire. There's opportunities, really some really cool stuff happening in the quality measure space, where we're looking to evolve from our handwritten narrative quality measures to things more like ECQMs, where they're computable, but ultimately represent the quality measure from the authoring side as a computable artifact. We call it CQL, or clinical quality language, and define what is the data that supports the quality measure, so that we can generate and retrieve that data from the EHR through one of the implementation guides Da Vinci has done called the Data Exchange for Quality Measure, where we can query EHR for the quality measure data based on a defined definition of the quality measure, and then retrieve it, send it off to a secondary user like a payer, and then ultimately report it to a reporting agency like CMS or NCQA. And we want to make it so that it's fire and computable from end to end. And so there's some really great work. NCQA is going to be having their Digital Quality Summit in July, and we're going to look at how we expand the ecosystem and start training folks to understand how to use CQL and use fire. So there's always been a question around security and fire. So fire in and of itself is not a security standard, but it uses existing standards like TLS and OAuth. And so depending on the implementation, like Smart on Fire, you can create Smart on Fire secure apps and use OAuth as the security paradigm. And so whatever is the best approach for the architecture is fire can support. So I'm going to pause there for questions. I think I still have a little bit of time. We could go into Da Vinci, but I'll pause there. And Lorraine, if you want to have folks ask questions, or I can talk a little bit about DaVinci.
Yeah, there is one, Aaron does have a question before we go into that. And then we'll just give a reminder, mute if you're not asking a question, then you can unmute for questions. Aaron, go ahead.
Yeah, it's really exciting about the quality measure exchange. And I was wondering if you could talk a little bit about the maturity of that, how many folks are working, participating in that, if anyone's doing that in a production environment and basing payment on it yet, sort of the timeline related to that.
Alrighty, so the question was the participants in DaVinci and production level work?
Specifically around the quality measures exchange that you were talking about?
Oh, okay, great. So folks are looking to do piloting around the medication reconciliation post-discharge, our first example. They're looking to implement it in pilots later this year. We have at least one of the major vendors looking to pilot it, and several vendors who support the payers want to pilot this. So part of the DaVinci process is to identify use cases, develop the implementation guides and the reference implementations, and then support the vendor community and DaVinci members specifically on creating the pilots for this. Because I think we really need to demonstrate this so that we can get adoption from the EHR vendors who can then make it available to their customers.
Just to confirm, you guys are adopting ECQL and the ECQMs and so forth?
Well, the work that the CCSQ folks are doing is taking the ECQMs. I think they have a priority order. They've already helped us do the venous thromboembolism, and they're going to take this ECQMs and convert them into CQL, the clinical quality language, so they can be represented as a FHIR measure resource instance. So like colon cancer, we were fortunate that colon cancer is a CMS measure, but it's also a HEDIS measure, and they're very, very similar, and that there was already prior work done by HEDIS in their implementation guide to represent the colon cancer screening criteria, the 4 or 5 tests, as CQL. So we started with what I've been calling upstream work, representing the measure as a FHIR resource, and then taking those examples and what we learned to help like CMS or ultimately registry authors take their measures and represent them in CQL. So it's part of a learning process because CQL is a query language and it's not readily, we're building expertise in it. And so we're learning best practices by doing this work in the DaVinci and EEQM. So we've done medication reconciliation. We have in ballot now colon cancer screening and venous thromboembolism. We have a list of candidate measures we want to do next, like childhood immunizations, I think, and breastfeeding and some others. And what our goal will be is we won't represent everything as DaVinci and HL7. We won't represent every quality measure as in FHIR. But what we want to do is to provide enough exemplars of measures so that a measure author or a measure reporting vendor has something to start with. So since we did colon cancer screening, we believe you could take that and draw the parallel to breast cancer screening, at least identifying the resources. There's administrative and clinical processes involved there too, but at least at the FHIR interoperability layer, there should be some good parallels.
Nice, thank you.
Did that help? Sure. Okay.
Okay, yeah, go ahead.
Other questions?
Not presently, but I'm sure there will be when you do DaVinci.
Okay, so I only have a handful of slides in DaVinci, but I'm happy we can do a longer discussion in DaVinci. And I'm the technical director for DaVinci, which means I'm contracted to HL7 to support the DaVinci project along with Jocelyn Keegan and Point of Care Partners, who's their program management. And we have Bob Dieterle, who's also in the program management office, and Linnell James as an advisor. And just as the PMO office, I want to thank CMS and the participation by Melanie and others in DaVinci and helping us with our priorities and actually helping get some of these use cases worked on. So we've been able to make great progress because of your support. So this list here is a list from just a few weeks ago, and there's actually a newer list, but I'm not allowed to share it yet, of the use cases that were worked on. The top two are the data exchange for quality measures, which is the quality measure work that I mentioned. The second one that we have had completed an implementation guide and is in STU1 ballot is coverage requirements discovery. And then we're currently working on and intend to put into ballot in July the gray boxes for documentation templates and coverage rules, the health record exchange, the payer data exchange, and prior authorization support. The way to look at this list is 3 major streams and then some additional things. The first stream is around quality measures, which I've described. So we intend to work on additional exemplar quality measures, and so that work is continuing. We have coverage requirements discovery, documentation templates, or DTR, and prior authorization is a stream of work around how to improve the prior authorization process. And then the third is around that health record exchange, the clinical data exchange, and payer exchange. And the idea there is how do you exchange this the clinical data exchange is provider-based data exchange, so information that comes from an EHR as the primary source that then goes to other clinicians or back to payers, as opposed to the payer data exchange, which is payer-sourced clinical data, whether it comes from claims, from lab interfaces, from their own gaps in care information, care management information, formulary or directory information, and so it's payer-sourced information. And then the other elements, other use cases below that kind of support those 3 work streams. So you can envision that quality measures has a good parallel in what we do in gaps in care, because a gap in care is in a sense, an activity, a quality activity that hasn't been completed. So we look to ramp up that work this year to look at how to represent gaps in care, and more importantly for the provider, who's providing them gaps in care information. Is it payers? Is it CMS? Is it professional societies, or all the above? And how can we help them deliver care by providing them this gaps in care information, then reporting it back to payers so that they know that the patient is receiving screening tests and other things in a timely way. The ADTs can help with notifications, so it's important to know if a patient's discharged, so you know that's the clock that medication reconciliation starts, or it may be important for care coordination. So these are a number of our use cases that we are working on, and we've also expanded some of the payer data exchange to work on formularies and directories as well.
I have a quick question. Could you go back to the prior slide real quick?
Of course.
So can you expand a little bit on the prior authorization support? I mean, I think we probably natively think about it as a prior authorization from an X12 perspective. Can you dive a little bit here in the context of prior authorization support and FHIR?
Sure, and if you, let me pause for just a minute. I'm going to try to pull up a slide that may help with this conversation. Okay. So you are correct in thinking about the prior authorization related to X12, because we know we have HIPAA-mandated transactions around X12, and where we're thinking about prior authorization is what can be done to support providers in the prior authorization process. So it starts with coverage requirements discovery. So the example that we use is the CMS example around oxygen. As a provider, one of the first things I ask when I go to order something is, do I need a prior authorization? So what we do is we would, at the time of ordering, we...
Ian, are you sharing a slide, a different slide?
Not yet.
I am
Just look-
sharing it. It should be painting now.
Oh, there it is.
There it is, yep.
Right, that's from the
Okay.
work group.
So if we think about the process, the first step is, do I need a prior authorization? So we developed this coverage requirements discovery implementation guide to trigger when the provider does an order review on an item such as oxygen. It triggers a query on a payer clinical decision support service, a CDS service, and returns the answer. And for oxygen, the answer is yes. You need documentation. You may not need a prior authorization, but you need documentation. And as part of CDS hooks, which is we can talk about it on another time, we can provide a narrative to the provider to say you need to document the diagnoses. You have to make sure you do a 5-minute walk with a pulse oximetry. You have to decide how much oxygen you're going to order. All these things that go into the CMS oxygen medical necessity form. So this is this first step. Do I need prior authorization? The second step, though, and what we're doing with this document templates and rules is, what are the data requirements for documentation and ultimately for prior authorization around a referral or a durable medical equipment? And it would be triggered by the same hook, but the payer now not only says, yes, you need a prior authorization or documentation, we're going to tell you exactly what that documentation or requirements are in a template. And that template gets sent back to the provider and launched as a Smart on Fire app within their workflow. And because we define the data requirements in advance for the structured computable elements of the data requirements, we try to retrieve that from the EHR and pre-populate that user interface. So if you need condition, then we could retrieve condition resources and pre-populate it. There's a question?
Yes, this is Mel, and I just wanted to add so that John will understand the coverage requirements discovery plus the documentation templates and coverage rules put together for the Medicare fee-for-service program. We have labeled that the Documentation Requirement Lookup Service, or DRLS. And I know Kim Brandt has slides that she talks about this. On occasion, Seema Verma will also talk about this. But I just wanted to make sure that you knew that CRD and DTR, when combined, is the Documentation Requirement Lookup Service. Thank you.
Thanks, Mel.
Thank you, Mel. So this goes a long way in my mind of helping reduce that provider burden. If they can know in advance what documentation requirements there are, if we give them a straightforward user interface to collect that information, we populate that information, that's structured information that's already available, that should go a long way to helping reduce the documentation burden. But not only that, what we're doing in the prior authorization support is packaging that information, taking whatever is necessary to transform it into elements in the 278, along with the clinical data for the 275, and being able to transform that so that it can be sent through clearinghouses where 278 is required.
Are you finding in this work that the X12 standards are sufficient for you to get what you need out communicated when you're pulling all this together?
That work is still being done, so I can't answer that fully.
Okay.
And I'm not the lead on this particular project. Bob Dieterle is. But the thought here is we want to maintain the FHIR data with as much fidelity as possible and detail, support the 278, but one could reasonably envision a day where this could be FHIR end-to-end, where you're not constrained by having to translate it into another standard.
Got it. Yep. Okay.
So essentially using FHIR to collect the information, to transform it, send it, make it back into FHIR, back to the payer, and get a response from the payer based on the information that was collected, so that the provider has a response to the prior authorization request in as synchronous a way as possible. And I think the challenge is that things like oxygen that have a lot of structured data, that's fairly straightforward. But when there's more complex decision making, that's going to require additional like clinical decision support. We have one vendor coming to Montreal that's going to test this approach, at least this documentation approach, around their clinical rules for hospital admission. So they're going to use FHIR data to feed their algorithms and then create an artifact that represents all the data that that came out of that algorithm, and whether we haven't decided yet, or they haven't decided yet, whether or not they're going to try to do the back and forth with the payer vendor. But they want to do this these first two parts. And this is another place where CQL, the clinical quality language, plays in, because when you're defining these templates, you can define the data elements as FHIR resources in CQL so that you can launch the queries against the provider EHR that you need to pre-populate that documentation. Alrighty, let me pause just again and switch back to my other presentation, and I'm happy to answer a question while I do that. Okay. Okay, and we'll resume. Okay. So I'm going to go on pause and Dr. Rocha has a question.
Hi, thanks, Viet, for this presentation. So one of the key things that as we develop FHIR, I mean, FHIR is a standard similar to HL7 v2 and v3, which was a standards developed by HL7 in the past. And one of the things that we were struggling with in the past implementation of these technical standards is the level of consistency with which these standards are being defined, developed, and then adopted by the community. Consistency is extremely important for ensuring semantic interoperability. And so I wanted to ask, Viet, what are his experiences in terms of the level of consistency with which the FHIR IGs that he's working on are being implemented by the community, and what are some of the key lessons learned or best practices that the team at CMS can take away when considering any FHIR-related project or when engaging with FHIR projects?
So that's a really good question. And to answer the question, I'm going to use a quick metaphor. Some have described FHIR as Legos. I think of if you had a commercial kitchen, you have a pantry with some standardized ingredients, generic ingredients. And you might have a kitchen that has tools like stoves and pots and pans, and you have chefs that know how to make, have skills. But all three of those together don't make a meal for you. What you need is a recipe. And the more you can define the recipe specifically, the better you can make a consistent meal. And any of us who've cooked realize that how challenging that can be. But these implementation guides are really those recipes. And the way we make good implementation guides is that we try to define the scope and the workflow and the exchange process and what needs to be exchanged, how it needs to be exchanged, when it needs to be exchanged, so that we can define those resources and create profiles when we need, and the operations in a way that when an implementer who's not participated in the use cases could pick it up and be able to implement it. And so one of the lessons we learned is we have contractors building our reference implementations. And the reference implementations, for those unfamiliar, is just a way to represent for a user or potentially a developer what the FHIR interactions would look like, the FHIR resources and operations would look like in a controlled environment. So for medication reconciliation, we created a mock medication reconciliation user interface. And then when the user completes that reconciliation and it clicks submit, we created a way to configure the endpoint where you send that data either to another reference implementation payer sandbox, or what we did at HIMSS, we could configure it to one of 6 different payers, and the payers configured their FHIR endpoint to support that medication reconciliation and the data exchange for quality measures implementation guide. And all we did was change that endpoint, and we could click submit, and we were able to successfully submit the medication reconciliation. And the only reason I think we could do that was that we defined that endpoint really clearly, and we did the testing to show that worked. And that's one of the big values of reference implementations, and why it's been so important that the contract support for CMS has built these reference implementations for CDR, CRD, and DTR, because we use those reference implementations to demonstrate the basic operations of the FHIR IG, but also we can swap out a payer or swap out a provider with a real working system and be able to still demonstrate that interoperability. So at HIMSS, for those who weren't able to go, we had a demonstration every hour that the interoperability showcase was open, and we had 8 different configurations of payers and EHRs across 4 different interactions that we demonstrated how we could do scheduling, we could write data to the EHR, we demonstrated the CRD with oxygen, and we showed the medication reconciliation using our reference implementation, sending data to 5 or 6 different payers. Then that would not be possible without clear implementation guide. So I'm going to try to be mindful of time, Lorraine. Do you want to just try to finish up these last few slides and discuss other topics on another date?
Yeah,
okay?
Yes, that would be great.
Okay. So this is a really... Okay, so this is a sample timeline of what we do in a FHIR use case. The Da Vinci Steering Committee and the operating committee and the members of Da Vinci give us a list of use cases that they want to work on. The steering committee prioritizes them and gives us funding approval to work on them. We create a team of subject matter experts drawn from our community. And when we decide that we have a reasonable scope, we take that scope and we write up a project scope statement and put it into the HL7 process, which makes it public for the rest of the health IT community to participate. And through the requirements gathering and writing the IG up here, we create the IG and we put it into the balloting process. And as part of that, we take what we write in the IG and create a reference implementation in the Health Services Platform Consortium FHIR Sandbox. And so this is an iterative approach to create the spec, test it out, go to connectathons, and try to improve the specification of the implementation guide to the best we can to get it to that either a comment level or a STU level, and then put it into the ballot process. And so we've been pretty successful at this, and what we've done is really pushed HL7 to be more agile and working even faster with implementation guides. This is an example of a simple reference implementation. In the middle is where really we do the Da Vinci work of writing the implementation guides, where we define the resources and the APIs and the interactions. But we also create these reference implementations of the payer and the provider. And of course, we would just swap out one or the other, or ultimately both, with real production systems, or at least testbed systems, to do testing at connectathons. This was the example that we did at the HIMSS Interoperability Showcase. And if you want to jot down, if you go to YouTube, you can see a video. If you Google or YouTube search on unlocking payer data, you'll see a recording, a very nicely edited video of what we did at HIMSS. And I apologize in advance that I take up a little bit too much time on that video, but I was the moderator and was trying to explain what was happening through the course of these different interactions. But we took this patient from primary care to specialty to hospital back to primary care. And here's just a list of information, and we'll send out these slides for you all to take a look at. So I'll pause. I don't know how much time you have, but I'm happy to stay on and answer questions.
Does anybody on the phone or in the room have questions for Via? I think he would be kind enough to come back for anything but specific, but does anyone have a burning question now? No?
Nothing from me.
All right. Well, I want to thank you very much for taking time. I know you have another session this afternoon, but I really, really appreciate it, as we've said. And thanks everybody on the phone for participating today. And those of you in the room, as I said, I'll be sending out a survey tomorrow. It's automatically generated for everybody who was on the distribution list. If you didn't sign in, please do, or send me an email so we can get your feedback on today's session. It's really important so we can continue that for the collaborative and for other programs that we'll do. Again, thanks very much to our presenters. Really appreciate your time and everything that you put into doing that. We can give extras back. So thank you. You all are at liberty, and have a great rest of the week. Appreciate everybody.
Thank you.
Thanks everyone on the phone. Have a great rest of the week. Take care.
Yeah, thanks.
One more to go.
Do you have another one with